Okay, this is our last very brief video on osteoporosis and drugs for bone density. So bone density. So traditionally when we have to think about bone density, we're going to be thinking almost always about osteoporosis. Historically, postmenopausal osteoporosis, but not always postmenopausal osteoporosis. Men can have osteoporosis as well. Sometimes people that have bone cancers have bone density issues, and that will be picked up by elevation in blood calcium, because as the bone breaks down, calcium is released into the blood. And there's a disease called Paget's disease, which also causes issues with bone density. So we're not here to talk about all those diseases, but we are here to talk about ways to treat bone density. So historically, I'm just going to put this is the only slide I have. I'm just going to put all this up and then I'll talk to you. So historically, bone density was, especially with women, there is a increased risk of of osteoporosis. Osteoporosis is just basically when the bones become more brittle. And normally we have this situation where we're building bone and breaking bone down at about the same rate. Actually, when we're younger, we build bone faster than we break it down, and then for a period of time, we kind of, are held in balance. The cells that build bones and the cells that break bones down do so at the same rate, so bone density stays static. And then as we age, we start to break bone down faster than we're building it. And so the bones can become then more brittle. So osteoporosis, so there's kind of different gradations of this. Osteopenia means a little bit of bone loss, but not yet diagnosed as osteoporosis. And as that continues to get worse, then we would see the diagnosis of osteoporosis. The diagnosis of osteoporosis is traditionally made after a bone density scan. Usually they'll do a scan called a DEXA scan, which is kind of a confusing scan. The results are sort of confusing, but essentially they compare the bone of that person to like a 20-year-old. So it's not uncommon if you're 40 or 50 for your bones to be less dense than a 20-year-old, because we're in the breaking bone down, but there's like standard deviations below what would be considered normal, and that's how the diagnosis is made. So historically, how we've kind of approached this in women, because women, there is a relationship between the loss of estrogen and the density of the bones. So it's more common for women as they approach menopause and the first, let's say 5 to 10 years after menopause, for women to lose bone faster than men at the same age. But after that, roughly about 10 years after menopause, it's sort of an equal opportunity disease at that point. Men and women are equally likely to develop bone. It's a little more common in women, but men develop osteoporosis as well. But there very definitely is this estrogen relationship that the presence of estrogen tends to protect the bones. So historically, women, postmenopausal women, or women as they approach menopause, were treated with estrogen because that is something that definitely has been shown to be effective. However, estrogen carries risks of estrogen-dependent cancers like uterine cancer, ovarian cancer, and breast cancer. But it seems to be protective against colon cancer. So all kinds of women were on estrogen, and then we're seeing increasing cancers, estrogen-dependent cancers, and now we know more, like some cancers are estrogen receptor positive, so very definitely those probably were the cancers that we were seeing versus estrogen receptor negative. But anyway, the long and the short of it is estrogen was used a lot. We talked about estrogen in the previous slide, so I'm not going to talk about estrogen in the previous video, pardon me. I'm not going to talk about estrogen right now because I already did. But I want to talk about some alternatives to estrogen. So most often people with osteoporosis are administered this class of drugs right here, which are the bisphosphonates. I'm going to talk about them first because these are the ones I want you to remember mostly. Fosamax is a pretty good example that you might be familiar with. Diadrenal, Actinol, those are all examples of bisphosphonates. What bisphosphonates do is they inhibit the bone reabsorption, both abnormal and normal bone reabsorption. So basically what they do is they slow the breakdown, and you might even, and you can see it right here, there is a slight annual increase in bone density, and it seems to be most profound, not that it's very profound, it's just like about 2 to 3%, in people who have severe disease. If somebody has mild to moderate osteoporosis, you might just see it sort of stay steady rather than increasing bone density, or you might see like a 1% increase in bone density. But the other thing so estrogen traditionally has about that same degree of efficacy, but estrogen tends to plateau after a couple years of therapy, and then they might continue to lose bone mass, whereas with the bisphosphonates, they don't see that plateau. They hold steady and maybe will continue to increase over time. There's all kinds of different ways to get Fosamax in. There's like once dosing every day, there's dosing every week, there's dosing once a month. They've gotten really pretty creative with the dosing. So there's all different sorts of versions of this. There is a new kind of bisphosphonate called Zometa that has to be infused. And it's really only approved for severe bone wasting diseases like Paget's disease or bone cancers. But you can see they did do a study on 351 women and noted in that study that just a 15-minute infusion of Zometa once a year increased bone density of 5%. So that might be something we'll look at in the future. Right now it's really expensive, and so it's limited by that, but that's something to kind of think about. So what you're remembering here is bisphosphonates are the alternative to estrogen for treating bone density, and are by many considered the drug of choice because of the risks with estrogen. A lot of people kind of are a little nervous about estrogen. There's another kind of cool class of medications called the selective estrogen receptor modulators, or abbreviated as the SERMs. Avista is an example of that. So these are only good for postmenopausal women, and they basically stimulate some estrogen receptors and inhibit the others. So they seem to stimulate the estrogen receptors in the bone, so they're protective. It acts like estrogen in the bone, but then they inhibit the estrogen receptors in the others. So they prevent bone loss. They don't seem to do anything for hot flashes. That's the difference. They seem to inhibit those receptors. They do seem to lower LDL cholesterol, which oftentimes climbs up around menopause, but they don't raise HDL. That's the protective one. They do seem to contribute to I do not think they contribute to thromboembolism. I have to look that up. They do not seem to stimulate breast or uterine tissue. While I have you guys here, I'm going to look in a book really quick, see if I can find that, because that seems like it might be a typo, or if else I just don't remember. Hold the phone for 1 second. Let's find drugs for SERMs 226. Let me consult my little text here, see if it says anything. Oh, they do. I do have it right. So they do seem to contribute. So the SERMs can, like estrogen, contribute to thromboembolism. Okay, so I'm glad I looked at that up. So that is right on my slide. But they do not seem to stimulate breast or uterine tissue, so that's a plus. So they're like estrogen, but they're not like a full-blown estrogen administration. And then down here at the bottom, these are relatively newer drugs, parathyroid hormone stimulators. They seem to turn on osteoblasts, the bone builders. So there's a little worry, maybe potentially we might see some cancer, bone cancer. I don't know if it's been substantiated. These drugs aren't used that much. An example of a parathyroid hormone stimulator is Forteo. Forteo gets injected once a day. It's basically a parathyroid hormone fragment. There's another one called Prios, which is a full-length parathyroid hormone. So again, they are going to be reserved for severe osteoporosis that's resistant to any other treatment if they were continuing to lose bone mass. And they have to be injected, and they have to be injected once a day. So and they have historically been pretty expensive. That's especially when they hit the market. They were, really, really exorbitantly priced. So that was challenging. So that's about it for the drugs for osteoporosis. So again, our options are estrogen with the risks, SERMs. If you really wanted to use estrogen, but you are afraid of the risk, you could go with the SERMs, even though you're not totally out of the woods, right? There still is the clotting potential, and it doesn't seem to help with the other menopausal symptoms. So most people would probably opt for the bisphosphonates. Those are really considered the drugs of choice for most people for osteoporosis. Oh, one thing I do want to mention with bisphosphonates, there is, I don't know why I did not put it on there, there is a risk, and it seems to be, depending on where you read, sometimes it's downplayed, but there is an association with, and I can't explain why this happens, with breaking down of the jaw bones. So there's some bone loss in the jaw, which I cannot understand really how that works. I actually just had a conversation about my dentist because I wonder with him about it just last time I was in. I asked him if it's something he sees with any degree of frequency, and he actually said yes, it is something that he has seen more often than he would like to admit. So I think that is something to pay attention to, and you can read about that in any drug book, but just something to note. All right, so that concludes, you guys, I believe. Oh, here's a picture of the parathyroid, what parathyroid hormone does. Parathyroid causes release of calcium from the bone. It causes increased calcium reabsorption from the kidney and increased absorption of calcium in the small intestine. So it causes higher blood levels of calcium in the bloodstream. Did I say that right? So, yes. Okay, that's good enough. And the other hormone here that plays a role in blood calcium is calcitonin. Vitamin D. Vitamin D is really important for calcium absorption, right? So vitamin D comes either from the diet in an inactive form. It gets activated by sun in the skin, and ultimately it is responsible for helping us absorb more calcium in the small intestine. So that's a deal. So this is kind of the summary of osteoporosis. Normal bone, you're depositing bone and breaking bone down at about the same rate. If you're not depositing and you're excess breaking down, that is what osteoporosis is all about. Okay, so that's it. You guys did it. This is pharmacology, introduction survey of pharmacology. So don't forget about your homework. Your final exam is to come. It will be 75 questions. It will be 150 points. You'll have 80 minutes to complete it. I hope you feel like you learned some stuff in this course, and I would love to see you guys in another class, hopefully in person. That would be nice. Email me with any questions that you might have. All right. Have a good evening.